Good afternoon, everyone. I hope everyone is logged in successfully and can hear me okay. We'll just give a couple of minutes for everyone to get online, but welcome to the Year 7 Reports launch webinar. Today we're going to be talking about all things Year 7 report. We've got a few speakers today. So we've got Dr. Sally Ann Wilson, who's an ED consultant and a NELA CRG member who's going to be talking about NELA in the emergency department. We've got Miss Lindsay Pierce, who's consultant surgeon and our NELA surgical and research lead, who's going to be talking about the key messages from this year's report. And there's myself, my name is Hannah. I'm a surgical research fellow from the East Midlands, and I'm going to be talking about the main messages of this year's report. So before we start, we will be having a Q&A session at the end. So please submit all your questions and comments through the Q&A tab. If we are having technical difficulties, if you can't hear us or you're having visual problems, please exit Zoom and restart it. We are recording today's webinar and it will be available in due course. And please, 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 at the end, would you mind completing the post-webinar survey? We really like hearing what you guys have to say, and we want to make these as useful as possible for you. So any feedback is very much appreciated. Please save the dates. Thursday, the 22nd of January 2022 will be our next webinar. So in the new year, talking about the emergency laparotomy patient journey. So without further ado, the 7th National Emergency Laparotomy Audit Report that came out in November, we're going to talk about the key points and what you need to take away from this report. So undoubtedly, it's been a difficult year. It's been a difficult couple of years. This report covers December 2019 to November 2020. So really the first wave of the COVID pandemic and the beginnings of the second wave. But despite this, 177 hospitals contributed data to this report, and we gathered a total number of patients of 21,846. And we really would like to say that this is an absolute testament to the dedication of the NHS trusts, Welsh health boards, and local audit teams who continued to upload data and really worked so hard on this despite what was incredibly trying times. So a really thank you very much to all of the teams out there that have helped us with this. So who were our patients? Well, the Year 7 report has 20,248 patients from England and 1,598 patients from Wales. There was a slight female preponderance to our patient cohorts, and nearly half, 43.5%, were assessed as being high risk of death in the 30 days after their emergency laparotomy. About half of the patients required surgery within 6 hours, and just under 5% of their emergency laparotomies were for a complication of elective surgery. We have an interesting patient spread in terms of age. 55% are over 65. About a third are between the ages of 40 and 65, and just 10% are under the age of 40 years. About half of the patients we perform an emergency laparotomy on have a bowel obstruction. 11% have ischemic bowel. Just under 40% have evidence of infection or inflammation at emergency laparotomy, and a very small number, just 1.4%, have bleeding at emergency laparotomy. The most common procedures for Year 7 were small bowel resection, followed by adhesiolysis, then Hartmann's procedure, and finally the fourth most common were right hemicolectomy or ileocecal resection. So then, the good news. What have we done well in Year 7? Well, there's been excellent engagement with risk assessment and the NELA web tool, with 85% of our patients receiving a preoperative assessment of risk, which is up from last year and up a huge percent from our first year. So that's really good. And our management of high-risk patients has been good. 94% of patients with a high risk score documented had consultant surgeon input preoperatively, and 75.5% had consultant anaesthetist input preoperatively. We've improved our dual consultant presence intraoperatively. 90.1% have dual consultant presence if they are high risk. And out of hours, we're now up to 85.2%, which is a big jump from last year and is really good. Overall, 82.3% of high-risk patients were admitted to critical care after their operation. This is down a little bit from year 6, but given the circumstances and the COVID-19 and how that affected our critical care services, really, this is really excellent to see that most of our patients still managed to get into critical care despite what else was going on. Year on year, the length of stay for these patients has reduced. The median length of stay this year was 15.1 days, which is down from 19.2 days way back when we started nearly 10 years ago. Some things to focus on in terms of patients who are at risk of a prolonged hospital stay. So the length of stay is nearly double in older patients compared to younger ones. And you see the same phenomenon in ASA 4 versus ASA 1. And again, in high risk versus low risk. So these are the patients we really need to be focusing our attention on. An unplanned return to theatre puts your hospital stay up to nearly a month, as does an unplanned admission to intensive care. The 30-day mortality for the year 7 report was 8.7%. And you can see from this graph how we've improved this year on year since we began. Now, there were slight spikes this year, and you can see how those relate to the waves of COVID. We have gone into a lot more detail about COVID mortality, and all of that is available in our COVID interim report, which is on the NELA website if you want to look at it. So then the room for improvement or not so great news. There's always room for improvement, and these are the things we really need to start tackling for our next year. So as always, there's variation in access to theatre. We do see this year on year, and it's a problem for lots of hospitals. The thing we really need to focus on is that these patients, NELA patients, a huge cohort of them are patients presenting with sepsis, and therefore timely access to theatre is really important. The standard that we want to aim for is that 85% of patients arrive to theatre in their urgency window, so either immediately under 2 hours, between 2 and 6 hours, or 6 to 18 hours. In the year 7 data, 80.9% of patients arrived at theatre in an appropriate time frame. We do best for patients that need their operation within 2 to 6 hours. And unfortunately, we do worst for patients that need immediate surgery in under 2 hours. So that really is something to focus on. There's also, unfortunately, a big variation in sepsis treatment and timeliness to antibiotics. About a quarter of NELA patients present to A&E with suspected sepsis, and unfortunately, 78% don't get their antibiotics within the first hour. And 1 in 10 patients receives their first dose of antibiotics in theatre, which can be 15 hours after they've originally presented. So really, sepsis management, early antibiotics are things that we need to take away and focus our energy on. And we can improve the care of older people and people living with frailty. 55.4% of our patients are aged over 65, and 1/3 of these patients are living with frailty. We know already that patients living with frailty that have emergency laparotomies are at higher risk of complications, have prolonged hospital stays, and are at higher risk of mortality and of needing extra care on discharge, so like discharge to a nursing home. And the important thing is identifying their frailty. And happily, we can say this year, 91.8% of patients aged over 65 had their frailty status assessed and documented, which is a complete achievement considering that we've only started really concentrating on frailty in the last couple of years. So really well done. However, once you've identified frailty, the next thing to do is to try and mitigate its effect on their recovery. And a big part of that is being able to have a multidisciplinary team review afterwards and consultant geriatrician input. Now this year, 27.1% of our patients aged over 80 or over 65 and living with frailty were assessed by a geriatrician. As you can see from these little heat maps, on the left-hand side is year 6, and on the right-hand side is year 7. Unfortunately, there was a slight decrease in the number of our patients that were able to be assessed by a consultant geriatrician between year 6 and year 7. Now, it's difficult to say why this is, but it's probably a function of this year. The way that we've redeployed medical services to deal with COVID has unfortunately resulted in a small decrease. But these have got implications about future workforce planning, consultant recruitment, and how we divide up our services. So then, a whistle-stop tour through year 7 data. We did a lot of things well, and importantly, we did a lot of things well despite an unprecedented global pandemic. So a huge thank you to all our teams. However, there are still a number of key areas that we need to focus on, and we have a number of key messages that we'll be discussing later with Miss Lindsay Pearce. And we'll move on to our next speaker.
That's fantastic. Thank you, Hannah. That was a fantastically succinct and very informative rundown of the year 7 report. So thank you for doing that. Sally is just dialing into the webinar at the moment. So we're just going to give her a little bit longer to dial in. I've only got one question at the moment that's come up in the QA box. So we'd like a few more questions if that's possible. The question that's come up, I'm going to throw this out to Hannah actually immediately. And see what she thinks. So an anonymous attendee has said, quick question, any prediction for how long NELA will carry on, maybe 2 or 3 years more? What do you think, Hannah? How much longer has NELA got to keep going for, or have we got to change things?
Interesting question. Well, this year...
Go on, put your camera on because we can't see a lovely Christmas tree.
Next year is NELA's 10th birthday, and I think no one would argue that we've had a huge influence on how things are run for our NELA patients and produced better outcomes for our patients. I think indefinitely until we're meeting our standards, I think, and I think there's enough evidence that there's still plenty of standards that we could improve on. I don't think NELA's going away anytime soon.
Fantastic, thank you. Right, Sally, welcome. Thank you for joining us. Do you want to go ahead with your presentation now, or do you want me to jump in with key messages? Up to you.
I'm happy to jump in.
Okay, lovely. Right, so I'll hand over to Sally, who's going to present a bit more of an ED focus slant on the National Emergency Laparotomy Audit.
Hopefully you can see my screen.
Yeah. We can see your slide screen, but we're not on presenter view at the moment, Sally. So if you just put us on to presenter view, that would be great.
Right. This is why I should join in first.
Click on play from the beginning at the top left-hand corner of your screen.
Yeah, I'll just come out again and unshare. Sorry, do you want to jump in and I'll get that sorted rather than waste folks' time?
Yeah, no problem. Right, so you're challenging me to screen share now. So you need to stop sharing yours so I can share mine. Fabulous. Okay, right, let's go for this one. So key messages. So there's a number of key messages that have come out of the report. Let's see if I can get us onto presenter view. Yep, okay, you're able to see all of that. Fabulous, lovely. So key messages, there's 5 essentially that have come out, and Hannah's touched on those in her presentation. So key message 1, high-risk patients undergoing emergency laparotomy do not consistently benefit from early recognition, and this is where Sally really comes in with her presentation. So I've been talking for some time about how, from my perspective, I feel that we're not doing too badly at that kind of process where it's between decision to operate and getting to theatre. Yes, there's things that we can improve, but we have made significant improvement there. But what we don't know about is what happens before that decision to operate, and this is where this key message really comes in. So we want NELA leads for emergency medicine in all of our emergency departments with job plan time, and we want them to be working with the anaesthetic, surgical and radiology leads to try and create some interdepartmental pathways, if they don't already exist, to try and manage those patients with acute abdominal pathology a bit more in a bit more of a timely fashion. So I'm hoping that Sally will touch on some of this in her presentation. It's really important that we get adequate triage processes. So we want you to be looking towards your ED triage team, your urgent care centre, to really make sure that we flag up patients with acute abdominal pathology at an early stage, and that we don't just get referrals to surgical teams, you know, as they approach their 4-hour breach time. We want multi-professional care, and we want everything to be evaluated regularly in your departmental meetings. So implement some changes, see what the effect is, and then continue to evaluate those changes over time. Key message 2 really relates to sepsis. So this is something that has been a problem within the last few years of NELA reports, that we're not really making significant inroads in time to antibiotics. And what we'd like to do is try and bring that much earlier into the patient pathway. So we don't want antibiotics being given at a time to operate. We want antibiotics being given pretty much as soon as the patient comes through the front door. So we want antibiotic therapy to be given in line with national guidance. We want you to use your local NELA data to constantly evaluate how you're doing that, and present that information into departmental governance meetings, linking with people that are involved in the pathway that you think perhaps where some of the steps might be falling down. So don't just wait for the annual reports to come out, really tap into those quarterly reports. Radiology. So radiology they're in a difficult position at the moment in terms of their workforce, and so outsourcing of radiology reports is something that is not going away. It's something that we need to be able to work with. And we recognise that patients don't consistently benefit from in-house consultant reporting, and outsourcing is common. But what we really want organisations to do to really try and look within their local workforce, particularly at utilising registrar workforce, to try and use them a bit with consultant supervision for preoperative CT reporting, because we know that discrepancy rate is lower than it is with outsourcing of radiology reports. So local workforce planning, make sure that we've got a NELA lead for radiology, again with specific job plan time. Look to your trainee workforce with consultant supervision and training, and ensure that the reporting of CT scans for the NELA patients is a standing item on review meetings, and make sure that any discrepancies are reviewed in realm meetings. Key message 4 relates to frailty, which again, Hannah talked around frailty. We know it's an independent marker of poor outcomes, and frail patients should be considered to be high risk regardless of risk score. But we are still seeing that geriatrician input is generally poor, and we know that patients do benefit from that input. So we'd like to see formal assessment and documentation of frailty for all patients over the age of 65, and consider frailty scoring really an integral part of that formal risk assessment. And geriatric medicine services need to have adequately job planned capacity to be able to work again with the local NELA leads, both ED, radiology, surgery, anaesthetics, to try and improve outcomes for our older patients. And then finally, quite a small proportion of patients, but accumulatively over the years of NELA so far, we have got quite a number of patients who've had what we term a negative emergency laparotomy, so no significant intraoperative findings to account for the acute abdominal pathology. And what we'd like to see is some review of decision making, review of processes, of patient pathways for those patients, just to make sure that we're feeding back and getting some clinical learning through our departmental governance and quality improvement processes around patients who potentially have undergone an unnecessary major operation. They're sort of a bit of a forgotten group, but anybody that undergoes an emergency laparotomy that hasn't benefited their care potentially may have significant problems associated with that, and we know that they've got a high mortality, so we'd really like you to look at that forgotten group. So those are the 5 key messages that are included in the Year 7 report, and look forward to seeing hopefully some pieces of work coming from those key messages, and please do take them to your medical directors to try and say, look, you know, this is what the recommendations are, so there's no hiding. Right, Sally, I'm going to hand over to you now, so I'm going to stop sharing my screen so that you can jump back in with your presentation, if that's all right, if you're ready. I'll have a quick look through the Q&As while we're going. We've got a few more in, that's fantastic. I'll have a flick through those. Keep the questions coming, and I'll try and put together some questions for Hannah and Sally at the end of the presentation.
Right, we will give this another go. Have you got my whole screen this time?
I'm sorry to say that we haven't, but just crack on anyway, it'll be fine.
If you say, do you want to drive it then?
Christine, have you got Sally's slides to drive?
I do. I will give it a go. If Sally stops sharing her screen, I'll pull them up.
So anyway, I'm Sally Ann Wilson. I'm usually arrive on time. Not quite sure how I didn't. Anyway, I'm a consultant in emergency medicine in Airedale, on the edge of the Yorkshire Dales, and I am also the Royal College of Emergency Medicine representative on the NELA CRG. So I'm going to give you a little bit of an emergency department perspective on the 7th NELA report, and also mention some of the new data set that's we've just started collecting this month. Next slide. Yeah, so a quick background for anyone that's tuning in that isn't familiar with NELA. They started collecting data back in 1st of December 2012, so it's now the largest prospective collected set of data on patients undergoing emergency laparotomy. So the data is from over 150,000 patients, and you compare that to RChem annual audits or QIPs, when we get 12 to 15,000 patients a year. In those, this is really quite robust data. The original risk score that was used was P-POSSUM, but now NELA has their own risks prediction score based on the data that's been collected. And you can access that through the NELA website, but it does give you an idea of the risk of the patient in front of you, and it's very useful for the surgical teams and the anaesthetic teams thinking about taking your patient to theatre. And when we're talking high risk, we're talking over 5% or more risk of mortality. And there's been a real drive through NELA data and with the best practice tariff to really look after that high risk group of patients. And now over 90% of cases have got a consultant surgeon and a consultant anaesthetist in theatre with them. And the mortality has fallen from year 1 at 11.8% to now 8.7%. Next. So why should, from an emergency department point of view, we engage with NELA? Well, I've just said the mortality is 8.7%. If you think about the patients that we prioritise and triage as category 2 or orange, the query strokes, an ischemic stroke, 30-day mortalities in the region of 11%. And equally, all those chest pains that we look at and prioritise when an MI has a 30-day mortality very similar to the group that we're talking about for NELA. I look at the NRLS data for the college, and every year when we look at it, you can see in the deaths and severe harm that we have missed or delayed the diagnosis for patients that have acute abdomens. So really good reason for us to be engaging and thinking about this patient group, because what we're trained to do as emergency physicians is actually look after those and recognise those really sick people and give them the appropriate treatment. So it should be in our gift to help these patients. And often we do, but we don't always get it right. The college already acknowledges the risk of these patients from the NRLS data, especially in the older adults, but actually looking at the NRLS, also the patients that aren't able to communicate as well. So your patients with learning disabilities are also at higher risk of us missing out on the diagnosis. And it was added, I think back in 2016 now, as a senior sign-off condition for patients 70 and over with abdominal pain, should be discussed with a senior clinician before being sent home. And that's going to be re-audited from April 2020. So hopefully another good reason to engage with the NELA process. Local MDT approach can really facilitate learning and improve the care for the patients, so it can be quite a positive experience. And RChem recommends, as Lindsay has already said, that we should have a NELA lead, and RChem's got a position statement, and I've got the link there for you when the slides are available so that you can see the position statement, that we should really be on a par with the surgical anaesthetic and radiology leads within the trust. Next. That's just a quick picture of the safety alert that was out, just to highlight that we do recognise that we can get this, that we recognise this as a high risk group. Next. So they're the reasons why we should engage, but you will, I suspect, if you try and engage with your ED colleagues on pretty much anything at the minute, face a selection of barriers. We are having a tough time of it. The whole system is, I think. This is data from the Winter Flow project that the college does, and the end of November, the data was saying that 61% of departments are reporting that they're struggling to offload ambulances every day. So that's stacking patients in ambulances outside departments. More than 50% of emergency departments are providing care in corridors or in non-clinical areas, and it feels awful doing that. I've certainly sat out an appendicitis into a chair with a drip next to them because moving them out of their cubicle was the only way I was going to get a septic patient into a cubicle, and it doesn't feel like the care that we want to deliver. The RChem report, Crowding and its Consequences, found that about 4,500 patients have likely died because of crowding in our EDs in the last financial year. And there are longer and longer waits in departments for beds. So the end of November, 7.3% of ED patients were in department more than 12 hours, with some departments saying that patients are there up to 72 hours waiting for a bed. We have a finite number of staff to deliver that care, but not a finite number of patients. And because of all of that, most departments are unable to maintain social distancing. And in a COVID era, that feels uncomfortable too. Next. So as I said, we've got lots of competing targets and priorities within finite resources. So clinically, we've got plenty of targets: offloading ambulances in 15 minutes. We're not meeting triage within 15 minutes, variable. Seeing all our query strokes within 10 minutes. Getting SPA cancelled, I'm sure a lot of you have had the same situation, or being pulled out clinically to help when it's busy. And we are talking from an ED point of view, of a relatively small number of patients that end up as NELA patients. And I think so far, although I've tried, it has been a relatively low profile audit from an ED point of view, because until now, we haven't really had much data for us to really identify where some of the delays are. Next. Which leads me on to what our normal day looks like, and then some of our new data. So how many patients are we talking about in my ED? It's a small department, but I've looked actually at a few days now, and about 7% of patients, 7-8% come in with abdominal pain or constipation, vomiting, sort of abdominal complaints. And less than a third of those do we admit. And actually, out of my random day, we did have one NELA case, but that isn't the case every day, because in my trust we do about 100 NELA cases a year, which equates to a very small percentage of total ED attendances. Next. So on to the messages. Now, I know we've already just had a little look at that, but I really want to highlight that I'm really pleased that the first two sets of key messages focus on the care that we can improve in the emergency department. High-risk patients don't consistently benefit from early recognition of the acute abdominal pathology through our triage, our assessment, our investigations, and NELA and RChem agree that we should have NELA leads for emergency medicine. We should have interdepartmental pathways already to be eligible for the best practice tariff, pardon me, but we really need to have a look at those, make sure that we incorporate the voice of the people that are triaging. I don't do triage, but we need to make sure what works for the triage staff. We need to make sure that every step is accounted for and designed by the people that are actually doing it. There is little point in an anaesthetist say that 20 years ago worked in the ED designing our part of the pathway, just like it would be ridiculous for me to do anything to do with the intraoperative care. And we're not going to get these pathways right straight away, and it's really important for us to have that MDT approach to be able to say what's working, what isn't, and to be able to tweak these. Next. And thinking about the things that we're going to be looking at now. So from the data set that we've started collecting in the beginning of the month, the time of first assessment is now going to be a timestamp that's collected by NELA. And that isn't triage, that's when myself as a clinician gets to see that patient. And I think that is going to be a real driver for us getting engaged with this process. NELA has done a lot of work looking at how many patients are getting CTs and who reports them, but we're now going to have that timestamp as well. Certainly looking at our local data, the decision to operate is after the CT scan. So if the CT scan isn't ordered soon, then we're delaying that time to operate. And surely if you've got an acute abdomen, the sooner we can get that decision made and the sooner they get to theatre, that's what I'd want if I had an acute belly. Things that we haven't collected either previously are whether planned conservative management was first, because again, looking at some of the data, it's difficult to know whether we've been slow at operating or whether it's the ED that's sent to the wrong specialty. And we're continuing to look at the time to first antibiotic dose, which goes nicely onto that second recommendation next, which is around that management of sepsis and timely source control, which to me is going to theatre. We really should be looking after these patients and getting the antibiotics in within an hour. And we really should be looking at that data on a regular basis. Next. We know that just over a quarter of the NELA patients have signs of sepsis on arrival, yet the data says that we're not doing very well with that antibiotics within an hour data, 21.6% in this last year. The median time to antibiotics being 3.2 hours. And I have a suspicion, knowing how the departments are getting busier and busier, that that's getting worse rather than better at the minute. And we need to think about how we can improve that and not let it slide. 9% of patients don't get their antibiotics until theatre, and I do wonder how much of that is the holes in the Swiss cheese aligning, so that if we don't give the antibiotics in the ED, that they don't get given until they're in the anaesthetic room, and 15.3 hours down the line, perhaps we should get some antibiotics. It's not what I would want if it was me. And of course, people with sepsis have a higher risk of mortality. So again, should focus our minds a little bit on this group. Next. So what can I do in my ED? Well, appointing the ED NELA lead, I think, is going to be the key to get some time in your working week so that you can actually do stuff. Looking at NELA, engaging with your other NELA leads in the trust, meeting with them, getting that shared understanding and shared aims. What is it that we're calling sepsis? Who is it that we need to be giving antibiotics to sooner and we aren't? Co-design those care pathways, have time to look at your own data, learn what we do well, because there will be cases that are really quite encouraging, and all that learning from excellence and how can we do that more often, but also obviously identifying areas for improvement. Don't just have your NELA meetings that are with the other NELA leads. Make sure that you disseminate that learning and involve your triage team, your nurse educators, your junior medical staff in all of that. Next. When you are a NELA lead, you get access to all of the local data. This is our Airedale data on how well we're doing with our antibiotics. Slightly better on timeliness to theatre, but there's definitely room for us to improve. Next. Just to identify patients and being able to see when we do things well. It's really nice to see when things go well and celebrate. We had a lady that came in October that originally triage category yellow. She had her bloods done. The triage nurse identified her lactate was 5.9 and when we got one of my colleagues. And then actually, despite the CT showing that she had ischemic bowel, and we know that that's usually bad news, she did really well and went home at day 23. So that's really encouraging news to say that we can do it well when we are highlighted to someone sick right at the front door. Next. Sadly, we don't always get it right, as I said. And thinking about all the delays and how busy we can be, looking at this patient's timings. I know this department was really busy. Over half an hour for triage, another 8 hours before they were seen by a really junior doctor. That time was ticking for that 12 hours, have to get them moved off. So they were moved to care of the medics without any imaging done. When the imaging was done, the small bowel obstruction, I don't think was identified correctly or swiftly, or the what to do next wasn't thought about, because it was until very many hours later that they got the CT. And again, once the CT was done, the decision to operate was easy. Next. So just to conclude, most of our patients requiring an emergency laparotomy come via the ED. It's a high risk group of patients, and despite all the complexity and the pressure that we're under in the ED, I think we do need to engage with NELA. If ED aren't coming forward to do that, I'd encourage all the my other colleagues to go down to the ED and see who they can enthuse to join the team. So getting involved with the local NELA team and understanding our local data, I think, is what we should be doing. Thank you.
Thanks, Sally. That was fantastic. Thank you very much. So I've written loads of notes about your presentation. Some questions are coming in on the Q&A thing, but if you can chuck any more questions into there, I'll do my best to make sure that we answer those during this session. So I've got a question, first of all, for you, Sally, then. So Royal College have put out this position statement. We all sort of accept that this ED part of the pathway is so very important, but we want emergency medicine leads. Now, I'll bet your bottom dollar that there aren't many emergency medicine leads on the 93 participants that are dialed into this webinar right now. So we've got to set that up. So how do organisations get an emergency medicine NELA lead to get on board with them? What do they do? What do they say? Who do they speak to? What do you think the best approach would be?
I think the first step is talking to your own clinical director. And depending how they see it, whether that can get agreed straight away, but otherwise it's going to be talking probably with the other NELA leads to get you some more backing, and then going further up to medical directorate level and say, this group has high mortality, we really need to focus on it, and you need to invest in it, in us, with our time and money, so that we can actually deliver on this to improve patient care. I know, talking with other people, even the radiologists are struggling to get buy-in when money is tight.
Yeah. Money certainly does talk, doesn't it? I think it's just at the moment, given all the other pressures that we're under, it's going to be hard to get people to really open their ears and their eyes to the idea about how important this is.
Well, the other thought is comparing it to your trauma leads as well. So we've got trauma leads that have got dedicated time, as I'm sure the orthopedics, surgeons and anaesthetists, etc. do as well. And we're a relatively small unit, and it's double the number, but if you can justify it for 200 patients, surely you can justify it for 100 patients as well.
Yeah, absolutely. Great. Okay, so clinical directors and medical directors. I'm going to ask Hannah the next one about this. So then Sally talked a bit about kind of workforce and engaging nurse educators and all those kind of people. What do you think about surgeons going down into ED, Hannah? So do we have to wait to be called? Should we toddle off down there by ourselves and check in regularly? Is there a role for members of the surgical team to be based in ED? What do you think?
That's really interesting. Yeah, I think the thing is, you need to see these patients, don't you? And I think however we've set up medical school, I think lots of our patients come in out of hours, and lots of people don't feel like they have that experience assessing abdomens and picking up findings. Certainly, if someone calls me with a patient that sounds like they might be heading towards laparotomy, I don't wait for them to hit the ground in SAU. I go see them in A&E, in majors, and see if I can get the ball rolling, because you can't be an expert in everything. You know, the A&E registrars and SHOs, they've got a lot on their plate. And I think that we can provide that additional support of, have we thought of this? Have we managed to get that? Have we got things rolling? Have we got the group and saves? If we're giving that additional support, even if we just send the SHO, you know, it's important, and they know these things too. There are members of the team, and we could do outreach, I think.
Well, I'm still on mute then. I agree. I think, you know, that we shouldn't necessarily just wait to be called and presented with a fully packaged patient. We need to be in-reaching down to ED would be my feeling. And that can only help to strengthen relationships and build working relationships with our ED colleagues who have had a really rough time. Let's face it, we've all had a rough time, but ED have had a particularly rough time. And I just think being nice to each other is quite a nice thing to do, isn't it? So yeah, so I think surgeons should be drifting down to ED perhaps a bit more regularly than they do. Question for you again, Sally. So there's been a couple of questions about this, and it's something that's been raised in my organisation as well. CT requesting in ED. So some of the worst delays that we see in our patients, you know, for example, the 41-year-old man type patient that you describe, I think sometimes the older, you know, more unwell are a bit easier, but the ones who are younger perhaps compensated a bit better, but we know that they, you know, they're sick and they probably need a scan. We've had problems with advanced care practitioners requesting CT scans, and it takes quite a long time for that CT request to go through that loop of hitting radiology, being bounced back, being picked up by somebody else and going back around the loop again. So what's the best way to do it? Who should be requesting these CTs?
It really is down to talking to your radiology, certainly from a Yorkshire and Humber point of view. When we've talked about pathways across the Yorkshire patch, some departments, the juniors can request the scans and they get done no problem. Other departments, it has to be consultant surgeon to consultant radiologist. Yeah, and Hannah's raising an eyebrow because you know that you're not going to get a consultant surgeon at 2 a.m. immediately. It's not realistic. So having that good dialogue, and I think being part of the NELA team with the radiology and or being able to talk about this and negotiate your pathways, because it needs to be the people, yes, okay, if you've got a middle grade on it overnight, get it run past them, but you should be able to ring up and say, my middle grade's seen the patient, can we have the scan? It needs to be easy access, and we accept there's going to be scans that are normal, because otherwise we're going to be missing positive scans. So it probably will increase the number of people scanned, but we need to have good access.
Okay, fab, brilliant, thank you. Now, a few questions about robust data collection. So probably for Hannah, this one, I think. So there's a few questions that have come in about how do you make sure that our data collection for NELA is robust? And I think the questions really relate to those people who perhaps undergo an emergency laparotomy, but not in a recognised CPOD theatre or emergency theatre, or perhaps patients that haven't been admitted acutely through an ED and they've come in perhaps on an elective pathway and this is a return to theatre or whatever. So any advice for organisations about robust data collection and how best to do that?
Well, I think your trainees need to be included. I mean, I know we rotate, but you know, we just rotate to the same thing in a different place so that your trainees are involved. And then we try and at the WHO for the emergency laparotomy say, this is a NELA case, can we have the NELA paperwork? And there is a little trolley in our department where the sheets for the theatre coordinator nurse are where she fills in her paperwork, and in one of those drawers is the NELA paperwork, so the unfilled folder and the filled folder. So even if your patient is having theatre in theatre 9 at the opposite end, you can trot on down to the trolley that will always be there and get a NELA folder. But I think it's a team identifying the patient, flagging it up, this is a NELA patient, and making sure the trainees are also involved in collecting the data.
Yeah, I agree. I think it again goes back to communicating, talking to everybody, making sure that this is shared responsibility to collect this data, and it doesn't necessarily fall just to one person. But the trainees are really, really important and instrumental. And I know that there's a number of different processes. I think our audit department take quite a lot of control over the NELA data collection. In other trusts that I've worked in, it's very much you log into the NELA website and input the data yourself. So there's lots of different ways to do it. You just have to work out what works for your organisation, I guess. And if it's not working, then change something and do something different. There's a couple of questions that came in that I can probably answer. There was something about how do we get data on high-risk patients who did not go for surgery? Do you want to tell them about ELF, or shall I, Hannah?
I don't mind. So ELF is a national cohort study. It's on its second iteration now. So it first was looking at outcomes of people living with frailty who had an emergency laparotomy. And then we've just concluded data collection for people who didn't have an emergency laparotomy. So the reports on that will be out in the new year, and we'll have some really interesting findings, I think.
Very good, top marks for you, well done. Yeah, so ELF2 is where we're going to get that data from, hopefully. What's the best way to identify a negative emergency laparotomy? I think that's got to be through your coding department if you don't already know who they are. You should be able to pull all the negative emergency laparotomies also from the audit department through the NELA local NELA data set. So they're not difficult to find, there just won't be many of them, so you probably need to go back several years and really do a bit of a deep dive into those clinical case notes. Right, I'll swipe that one to the side. Conservative management. You mentioned conservative management, Sally. And I think that's a really, really important aspect about, conservative management is actively deciding to take somebody off an operative pathway, isn't it? It's not about, somebody comes in the evening and we're just going to sit on them overnight until the consultant comes in on the morning. That's not conservative management. So what's the best way for us to capture conservative management decisions, do you think?
I don't know. I'd love to have the answer on that one. I think if we've made the decision from an ED point of view that it's probably more likely that we think that they're not fit for surgery and we haven't involved the surgeons. But otherwise, I think the conservative management needs to be made from a surgical point of view.
Okay, so would you make that decision then that someone's not fit for surgery and not involve the surgical team? Okay, yeah. That's really interesting. What do you think about that, Hannah? Because that's something that's not really come up before.
I don't think all my juniors would, but yeah, we'll have a conversation with people.
That is really interesting. I think I can say that I've had a few, like that, where it was really clear that they were so desperately unwell, they probably wouldn't make it out of pit stop, to go anywhere else. But it's definitely been, the very few that I've had have been consultants, ED clinicians have called me and said, I don't think that this person is fit for anything and we're going to look after them as best we can and palliate them. But I think it's really interesting because it's a really difficult decision, I think, in most cases. And I myself have spent half an hour on the phone to the consultant overnight saying, what do you think? Or I don't know, it's borderline. It's just an impossible decision sometimes, isn't it?
Yeah, really tricky. Really tricky. Okay, last.
You've gone on to mute, Lindsay.
Sorry, I'm not going to learn that, am I? So yeah, somebody asked a question about CT scanning and adding of addendums. We have included a question about CT scanning addendums in our Year 9 data set. So we want to know, was there an addendum, I can't even say the word now, addendum added to the initial CT report, which altered the patient pathway or the decision to proceed with surgery? So we have covered that in Year 9. Let's have a look for any other questions. Oh, Richard Guy has asked a very interesting question about Hartmann's procedures. So I'm going to ask Hannah about this. So Richard said, the number of Hartmann's procedures is a bit worrying when we're all trying to join up more patients acutely. Is this a reflection of severity of disease or the surgical skill mix? Do you have any data on who is doing operations, i.e. specialists or generalists? I think one of your previous colleagues did some data around that. So I wondered if you wanted to just mention that briefly.
Yeah, well, I guess I'll ask the controversial question. Are we all trying to join up patients more?
Good. Answer a question with another question. Very good.
But in terms of skill mix, so my predecessor, Hannah Boyd-Carson, also a Hannah, she did a huge piece of work on specialists versus generalists. And I would only encourage you to read it, but essentially, if you're a specialist colorectal surgeon doing a colorectal surgery, your patients have a shorter length of hospital stay, fewer returns to theatre, and less mortality. And if you're a consultant upper GI specialist doing upper GI procedures, the same thing, vice versa. And I think it's driven a lot of moves to specialty on-calls in maybe the more medium hospital-sized hospitals that didn't have that before. And I think it's still going to drive future change. But yes, are we joining more patients up? Are we doing that everywhere, or are we doing that in a few places, I guess would be my question.
I feel like there's another NELA fellow project coming on there, honey. You've signed yourself up for something new. Okay, just last 5 minutes. Let me just rattle down some of these. Okay, we've dealt with the amendments. Any more questions, please do put them into the Q&A so that we can try and rattle through those. Is there a guidance or support tool for new leads? Now, making sure that we've got up-to-date information about who our NELA leads are is really important. So whilst you're thinking about who's going to be your emergency medicine lead, Please also make sure that your local NELA leads have also given us their contact details, so that we can contact them if we need to. I'm trying to contact a few people at the moment, and it's clear that we perhaps haven't got the right information for who the NELA leads are. It's really important that we do. So if you're a new lead, definitely get in touch and let us know what your email address is so that we can send you all of the information that we have. We have a section on our website of frequently asked questions. Any queries can come to the NELA help desk, but if there is appetite to develop some sort of how-to guide about being a NELA lead and the things that you need to know, then just let us know, because that's something that we can certainly look to providing, and be happy to do that. So let's dismiss that one. Next one. Someone said, have you any figures for the positive influence on care of the elderly medicine on NELA outcomes, survival and length of stay? So that started to come out when we were looking at the Year 7 data. We started to really uncover some interesting elements about our geriatrician input. And so we didn't go into great detail in the NELA annual report about it, but I think we're going to be looking at doing a special report probably just around the care of older patients. So that's that. We're now into the final 3 minutes. Oh, hang on, loads more have come in now. Help. Gemma Mullin encourages her juniors to go to ED, even when there's a rumour of a laparotomy patient, even if it's before a CT. Excellent. That sounds good, doesn't it, Sally? I think we can offer loads early doors, give antibiotics, and even help push the patient to CT or theatre. That sounds like a dream. Excellent. Where do you work, Gemma? Put in the Q&A where you work, and then we'll get you on a webinar. You can talk about it. Right, let's dismiss that question from there. Oh, is it time to stop collecting data for bloods that contribute to the NELA score? There are much better scoring systems already in existence and could replace many data points with just one. Then we could focus on outcomes and processes and actually have time to do something with the data locally. So data collection from blood tests, Hannah, what do you think?
Oh,
is that very onerous?
I don't think it's very onerous, particularly anymore, because we're all on patient track and e-results, and so they're right there and you've looked at them anyway to make a decision. But I think personally, I would say that it makes a difference to me whether the patient's got a lactate of 10, whether they're in renal failure, whether they're not in renal failure. All these things tell you, you know, this person is probably going to do worse, and these are things we have to think about. I think they're important considerations. I guess my question would be, what better score is there? Which one are you using, questionnaire?
So Alex, you need to get in touch with us and let us know. Brilliant. Right, it's now 1:29. I'm assuming that we're going to get booted out of Zoom in a minute. So thank you everybody for attending. Any questions that we've not had able to answer, please do feel free to get in touch with the NELA help desk or any of us, and we can try and field those questions for you. The next webinar will be after Christmas, 27th of January, when we're going to be doing some discussions around patient pathways and good elements. So Gemma, get in touch and let me know a bit more about your juniors going to ED. That would be great. All right. Anything that I've missed, Christine, who is behind the black screen but making sure that we're behaving?
I think we're all good. Thanks, Lindsay.
We're all good. Okay, lovely. Nice to see you all. Thanks very much for attending, and enjoy the rest of your day.